Thank you, Parmita. Good evening and welcome to this joint EUROGEN ERNICA webinar series. My name is Sara Roman and I am the Scientific Project Manager for ERNICA. Before I hand over to our speakers, I would like to briefly introduce the European Reference Networks, or ERNs. The ERNs are networks of hospitals and patient organizations across Europe that pool expertise, knowledge and resources to support patients with rare or complex diseases, as well as their families and healthcare professionals. The ERNs were established in 2017 by the European Commission. There are 24 of them, and each focuses on a specific rare or complex disease area. Today's webinar is a collaboration between two of these networks, EUROGEN, the European Reference Network for Rare and Complex Urogenital Conditions, and ERNICA, the European Reference Network for Rare Inherited and Congenital Anomalies. The webinar, titled Long-Term Continence Issues in Hirschsprung's Disease, Prevalence and Management, will be presented by Dr Alessio Pini Prato, specialist in pediatric surgery and director of the Mother and Child Health Department and the Pediatric Surgery Unit at the Children's Hospital AOU SS Antonio Biagio e Cesare Arrigo in Alessandria, Italy. His presentation will be followed by a presentation by Dr Silvia Tufano, specialist in Physical and Rehabilitation Medicine, with a clinical and research focus on pediatric and pelvic perineal rehabilitation, also from the same hospital in Alessandria, Italy. The webinar today focuses on Hirschsprung's disease, and in particular on long-term continence issues. Despite surgical treatment, many patients experience a reduced quality of life due to bowel dysfunction, including constipation and fecal incontinence. A multidisciplinary pelvic floor rehabilitation approach can play an important role in improving bowel function, reducing incontinence, and thus supporting better social participation. The webinar today is supported by ARMNet and UPSAP. So without further ado, I would like to invite our presenters to begin. So Dr. Pini Prato, the floor is yours.
Colorectal surgery and colorectal issues. And today's topic will be the long-term issues in Hirschsprung's disease, and in particular, continence, fecal continence issue. I have nothing to disclose. Fecal continence is not the only issue that can occur in the long term for patients with Hirschsprung's disease, as it is well known that those patients will experience urinary continence issue, sexuality issue, and some of the complaints, or at least of the fear of the families of the patient themselves, if regarding survival and earning capacity. But today we will focus on fecal continence, as it seems to be the most important issue, of course, regarding surgery that has been performed in the neonatal period. This is one interesting paper I want to show from the Dutch group that tried to develop a dedicated outpatient setting, outpatient clinic for older patients who's been operated on for Hirschsprung's disease. And they noticed that patients attending the clinic suffer from continence issue in up to 80% of cases. Though I want to underline that less than 20% of the patients attended the clinic. So this is an inclusion or selection bias, meaning that only those with complaints did present to the clinic. Anyway, this this paper underlined the importance of continence in the long term. This was already underlined more than 10 years ago by the Finnish group from Risto Rintala and Mikko Pakarinen, who showed that in the very long term, and we're talking about more than 20 years, up to 40 years of follow-up, patients who underwent surgery for Hirschsprung's disease, those patients reported in this paper underwent dual procedures, but anyway, those patients complained continence issue in around 40 to 50% of cases. And this is a huge prevalence of continence issue. The same authors later on focused on endorectal pull-through, so not on dual but on endorectal, and basically tried to compare totally transanal endorectal pull-through and laparoscopic endorectal pull-through. They sort of suggested that the total transanal could have a worse outcome, but anyway, they underlined that around 20% and more patients do complain continence issue, fecal continence issue in the long term, particularly if they've got a syndrome. But when addressing specific areas of function in terms of continence, they underline that not more than 50% of them can be considered as perfectly normal, as half of them experience seldom fecal accident, soiling, or other issue that impair with the quality of life and with the self-esteem. This is another interesting paper from the Dutch group that focus on ultra-long Hirschsprung patient, therefore on patients with total colonic ganglionosis. And when coming to this sort of more severe forms of Hirschsprung's disease, things get worse, as soiling or fecal incontinence can involve half and more than half of the patients, with important effects on quality of life, self-esteem, and social behavior. These awful results have been confirmed also by Prem Puri from Dublin, that in a meta-analysis showed that 50% of patients with total colonic ganglionosis will complain some continence issue, and we also confirmed and suggested that the impact of fecal continence in patients with total colonic ganglionosis is very important and involve more than half of our patients. And when fecal continence is impaired, severe excoriation, perineal rashes can occur. And there are many, many solutions that have been tried. For example, this is a protocol from Vilanova Sanchez from Madrid, and this is a similar protocol in our institution that tries to address the issue of severe excoriation by drugs, medication, screen barriers, and cream. But at the end of the day, the only way to get rid of this huge excoriation and perineal rash is that of normalizing fecal continence. This is why in the last years we decided to address this issue not only from a surgical point of view, but from a multidisciplinary point of view. And this is a recent paper that reported the results of our behavior on more than 80 patients with a classic rectosigmoid Hirschsprung. We developed this algorithm that separates patients without symptoms, those with obstructive symptoms, and those with fecal soiling or incontinence. As you can notice, pelvic floor rehabilitation has been a key part of treatment, both for asymptomatic and patient with fecal incontinence. But when focusing on fecal incontinence, we reported excellent results in terms of dealing with the symptoms and reducing incontinence or soiling by acting with a transanal irrigation, such as like peristeen. But more important, we developed this pelvic floor muscle rehabilitation, and Silvia will talk about it later, that provided out excellent results. And this is basically, I won't stay on this more than just a slide, but exercises performed in a very dedicated environment, which is dedicated to kids with dedicated professionals that basically try to rehabilitate patients that have undergone colorectal surgery, not only Hirschsprung's disease, either Hirschsprung's disease, anorectal malformation, and a number of patients with idiopathic constipation, fecal retention, and incontinence. And the results of our provisional experience that were collected through a prospective rehabilitation study and addressed 50 patients with either anorectal malformation and Hirschsprung's disease, and we could demonstrate that basically most of the patients, 47 out of 49, improved significantly in their continence scores, both just after rehabilitation, but even, and like in this picture you can see here, after 1 year. This means that the results that we can achieve with rehabilitation in the short term can be maintained throughout growth in the long term. And the same results can be observed when applying a Wexner, which is another score, which is even better, as only one patient did decrease the score. I mean, this is an inverse score, so the lower is the rate, the better is the outcome. And therefore, the dots do express that nearly all of our patients experience a significant improvement after this rehabilitation. So before passing the speech to Silvia, which will be much more interesting than myself, I want to underline, which is already known, I have to say, that fecal incontinence is a very important issue in the long term for Hirschsprung's disease, with total colonic ganglionosis, which behave worse than rectosigmoid Hirschsprung. And both these two aspects are well known in our practice. But this deserves a multidisciplinary approach, not only a pediatric surgeon perspective, because this involves a follow-up in the long term to address the impact of all our intervention, not only in the moment we do them, but throughout the growth of the patient. And in our experience, at least, the pelvic floor muscle rehabilitation has a crucial role to get rid of the obnoxious consequences of fecal incontinence. And this is demonstrated by the very large involvement of professionals that in Umberto Bossi Center for Digestive Disease do act in order to improve continence in our patient, including the specialists in physical medicine and rehabilitation coordinated by Silvia Tufano that will speak after myself. And I think that also the question time will follow her presentation. And I thank you so much for your
Good evening, everyone, and thank you for this opportunity. This evening, I'm speaking about a structured model, our structured model of pelvic floor muscle rehabilitation for children after colorectal surgery. No conflict of interest. Our reasoning follows the ICF model. The international classification of functioning, disability, and health provides a comprehensive framework for assessing and planning pelvic floor rehabilitation in children after colorectal surgery. It allows the integration of different items, body functions such as sphincter control and anorectal sensation, activities such as toileting skills, and participation, so self-esteem and also social inclusion, while considering environmental factors and personal factors as well. It supports the ICF model supports individualized goal setting and outcome measurement, promoting an holistic approach to fecal incontinence and management. The aim is not just to treat the underlying bowel pathology, but to address the functional deficit it creates and to minimize disability. The priorities are to secure age-appropriate fecal continence and the management of bowel symptoms to enable participation in normal activity and social interaction. Up to 50% of operated patients report a bowel dysfunction. The main symptoms are constipation, swelling, and fecal incontinence. They may determine an important impact in quality of life and significant psychosocial burden, and they can reduce autonomy as well. The severity of symptoms correlates with the length of the ganglionosis. The underlying mechanism of incontinence are related to problems with sphincter and pelvic floor. So, for example, they can correlate with weak anal sphincter or reduced perineal muscle strength, as well as they can correlate with motility problems such as intestinal hypermotility or abnormal rectal sensation. They also can correlate with constipation, so stool retention and overflow incontinence. Nowadays, rehabilitation is a well-accepted concept in pelvic and perineal surgery. It is effective for secondary urinary and bowel continence issues. It is also gaining evidence in pediatric patients. At our center, the Hirschsprung disease patients follows a structured long-term pathway. It is coordinated by pediatric surgeons and it focuses on stooling problems. The pediatric surgeon organizes a one-day assessment that includes also our assessment as well. First of all, during the physiatrist evaluation, we get to know child and families and introduce our role. Then we focus on personal history. And in order to individualize the program, it's very important the evaluation of associated anomalies, postoperative complication, and comorbidities. One important point is the degree of cooperation of the child. Age and adherence level are critical determinants for establish if a program is appropriate or not for this child. Pelvic floor rehabilitation require a constant concentration and engagement. And so if we introduce these demands prematurely, then it may cause frustration and so early discontinuation. So very important point. Then we focus on complications such as constipation, soiling, and urinary incontinence. We interview coping strategies, for example, the use of pads and medications, and precipitating factors for accidents. We assess also the psychosocial impact and measure the severity of symptoms, the consequences in everyday life, and on self-perception. It is increasingly evident that quality of life, impact, and psychological consequences are driven more by patients' perception of their condition than by disease-specific factors. Personal and social resources play a key role in individual well-being. So coping strategies influence subject well-being, perceived quality of life, satisfaction with health status, and overall health status. The point is adaptive coping, and so planning and seeking support in order to relieve stress and solve the problem. Evaluation scales provide a way in which we can objectify and measure the problem. So Wexner scale is considered the gold standard. It is widely used thanks to its ease to administrate. It was developed and validated for adult patients, and no specific validated score system currently exists for pediatric populations. The scale assesses the degree of incontinence based on the frequency of each symptoms, assigned a score from 0 to 4 to the 5 parameters. So accident with solid stool, liquid stool, gas, wear pads, and lifestyle alteration. The maximum score is 20 and corresponds to total incontinence, while the minimum score is 0 and corresponds to total continence. Another important tool is Rintala scale. It assesses the ability to hold back, the sensation, the frequency of defecation, soiling, accidents, constipation, and social problems. It's very easy to administrate. It can be completed by children and also by parents. And the maximum score here is 20 and corresponds to total continence. However, authors consider a score from 18 to 20 as a normal range as well. Score above 14 is considered as a good continence. Score from 9 to 13 as a social continence with some limitation in daily life. And then score from 5 to 9 with a lot of limitation in daily life. Bristol stool chart is another important tool to standardize the description of stools forms and estimate the bowel transit time. First of all, during the physical examination, we explain what physical examination consists of and why it is necessary. Then we start with the evaluation of the abdomen and perineal plan. We describe contraction assessing power graded by the Oxford scales And then endurance, repetition, fast maximum number, elevation, co-contraction, timing, and coordination. Then we observe the abdominal perineal protection reflex and the abdominal bombardment on coughing, which can indicate an inappropriate engagement of and coordination of muscle. Then we observe the perineal and perineal sensitivity. We assess surgical scars, searching for problem of adherence or, for example, hyperalgesia. And then we observe the overall posture in order to identify like patterns that can influence compensatory patterns that can influence the movement of pelvic floor. The first step of treatment is patient's education. That's very important. Pelvic floor is a structure difficult to perceive, which makes its management quite complex. So the first step is, that's why we introduce images or models of pelvic floor in order to explain the anatomy and explain how bowel works and how the defecatory pass should be performed. We stress a lot the toilet sitting programs. It's very important, and child should sit on the toilet immediately after meal for 5-10 minutes, 2 or 3 times per day, every day at the same time. And this routine should be followed also above all, during period of change, such as during holiday, travel, or weekend as well. Then we explain the correct position. So child should use a foot support under his feet in order to have the knees above the hips, and the trunk should be flexed forward in order to create a trunk to thigh angle less than 90 degrees. This position helps to relax the pelvic floor and reduce the anal pressure, which helps to expel stool, and so avoiding forced and prolonged evacuation. Oh, sorry. The second step is caregiver education. Caregiver should implement a regular toilet sitting program, and he should support the child's adherence through a positive reinforcement, avoiding negative reinforcement such as criticism or punishment. He should introduce a tailored reward system based on commitment, for example, correct positioning on the toilet, and not on success, such as evacuation, in order to avoid frustration. A follow-up with a logbook could be very useful to monitor the progress and changement over time. Treatment is organized in 6 sessions, delivered twice per month or monthly versus daily. Frequency is influenced by logistical issues. Many families travel a lot to reach our center, so concentrating the section in 1 week, it's easier to manage for them. First of all, the first point is awareness of perineal activity through periorificial techniques such as tactile and visual feedback. Then we guide the child to recognize the body signal, such as the urge to defecate. We work on sensitization and desensitization as needed. Then we correct the activation of agonist and antagonist muscles and reverse of motor commands. We work with selective muscle strengthening exercises in order to improve voluntary control. For us, it's very important to learn the correct respiratory synergy, and we focus the attention on the intra-abdominal pressure management. Automatization in daily life is selectively addressed. Then we work on posture, so overall posture, and core balance exercises are proposed. Finally, we work on surgical scars, if any problem of adherence or hyperalgesia, for example. The core of this program is biofeedback. It is a technique in which a physiological process is monitored, amplified, and transmitted to patient with a signal, feedback from the physiotherapist. The patient becomes aware of the non-physiological process that occur automatically. This role is played mainly by the physiotherapist. We prefer to not apply invasive intracavitary maneuvers when it's possible. In particular, the exercises work on muscle strength, relaxation, coordination, and contraction timing. It is based on a progressive resistance program. We try to achieve the overload stimulation beyond the normal performance level, thereby promoting hypertrophy. Then the program is designed on the concept of specificity, so training of the muscle in the way it must be activated physiologically. Maintenance, a long-term maintenance is very important. Exercises should be performed lifelong and regularly. So inactivity could lead to pre-treatment state. A clear concept of reversibility. Our goal is that we start initially the treatment exercise in a selective and static way. Then they are integrated with more global and dynamic movements. Finally, the goal is that they become part of daily life. We work with pediatric patients, so our program is child-friendly and fully customized. So we organize the program according to child age, for example, or impairment or motor skills as well. It is always play-based, and the therapeutic setting is made as comfortable as possible with the use of games. For example, we propose soap bubbles in order to teach how the correct way to engage abdominal muscle, for example, for a correct defecatory pass. We share always the program with child and parents, and the constant presence of the parent with an active and supportive role is essential. Physiotherapy is not a pill. It is a process, and the patient is the main actor. He plays an active role, and so to foster the adherence, we should share goals with him. Tasks must have a clear purpose, and they should not be too complex to cause frustration, and not too simple to cause boredom. We always give a booklet with advice and exercises to be continued at home. And we try always to support and motivate child to continue this exercise also at home. So, up to 50% of operated patients with Hirschsprung may complain of bowel dysfunction. A pelvic floor rehabilitation program with multidisciplinary care can improve bowel function, both in short term and in long term. Stooling control and accidents, as well as ability to discriminate stools consistency, improved after PFM rehabilitation. Bowel dysmotility is unaffected by PFM rehabilitation, so that's why it's very important in overall continence management, introducing also the transanal irrigation and the anterograde irrigation that has an important role. The protocol should be always tailored on patients' and parents' requirements. Thank you for your attention.
Thank you so much, Silvia. We would like to go over to the discussion section of the webinar. So again, like I mentioned at the beginning, for the attendees who have any questions, you can type in your questions in the questions field. You can find it in somewhere below. You have a Q&A with a question mark on it. That is where you can type in your questions. I can see that one person has already asked a question. I will go and see where Sylvia went, but if you, Alessio, would like to read out the question, then the people who watch back the webinar can know what's being asked and then answer it.
Yeah. So Marina Piotr asked, what is the difference in pelvic floor rehabilitation techniques for bowel problems and urinary problems, which often coexist with Hirschsprung's disease?
Okay. Depends on, for example, when we start with the fecal incontinence, then we focus above all on the, for example, synergy with the movement of diaphragm, abdominal muscles, and perineal gland. So working on a correct defecation path, while during urinary incontinence, we work above all on the bowel training, but if we start at the beginning, they have a lot of in common because child should first of all work on the awareness, so learn our body signal, and so I think it's very important, like these pathways have a lot of in common. So I think the main difference is in the training of correct muscle movement and coordination, I think. Don't know if I'm...
You answered to me at once.
Okay.
There's another question from Jamila Almari, and I'm not sure if she is asking to me or to yourself, but I will try. From your experience, was this the time frame when we could start see results and improvement in bowel function? If we talk about surgical point of view, which means they frequently have issues, mostly those with total colonic ganglionosis, they start being retentive and incontinent and sort of negative feedback because of pain and so on. I've observed that those that have no surgical issues or no requirements for redo or something like this, they tend to improve around 7 years of age. So I've observed many patients with total colonic after surgery, they start not pooing anymore, and you start needing to put rectal tube. And when they are 7, I don't know why 7, but I've noticed that this is sort of mental change. This is why we start rehabilitation at 7, maybe. It's sort of deadline when they start improving. But maybe they also ask yourself how long we should wait for observing improvements.
According to our study as well, we saw changement after the first 6 sessions, so after at the end of the program. And so maybe if it is monthly, then after 6 months or 3 months, it depends on the adherence of the program.
If I can ask you, would you prefer daily or monthly or weekly?
We prefer monthly or every 2 weeks, because we can monitor better the child, and we can have a long-term follow-up. So maybe if is there any problem, we can support them for a longer time.
There's another question, which is for yourself. And is it possible that you provide the booklets of exercises?
I think yes, but usually we give these exercises, this booklet after the program, because they should understand how perform the exercises. A lot of so if you have a physiotherapist with a specialization in pelvic floor management, then it's okay, because the point is to understand how do these exercises in the good way. And then, yeah, I think it's not a problem.
So you mean that if any of the surgeons or physicians that are connected has got in the team physiatrists, you can deliver the exercise so they can sort of copy your activity, isn't it? Is it
Yeah,
feasible?
I think it's not a problem. If we can help children, happy
Yeah,
to do that.
maybe they can leave at the end of the webinar. We send out a survey, and at this end of the survey, you can always leave some comments. So if you're interested in it, please leave it in the comment of the survey, and then I can bring you in contact with them.
Yeah, with the email we
Okay.
can change.
Yeah, exactly.
It will take, I think, a bit of time because it is in Italian, so we should translate it in English before. But I think it's not a
They
problem.
will translate it in another language. So
Yeah.
there's another question from Mahmoud Marey. What's the difference, between Hirschsprung's disease patients and those with anorectal malformation? And then there's another one from the same author. How do you integrate pelvic floor rehabilitation with bowel management programs? I think I can just say one thing. They are very different because anorectal malformation have weaker sphincter and Hirschsprung's disease have a sort of weaker sensation. And I've addressed all the results, and I have to say that they both do well after rehabilitation, and they seems to be dependent, of course, on the surgery that's being done and on the severity of the disease. So if we compare a very low anorectal malformation with a total colonics, of course, it's better to have a lower anorectal malformation, and therefore it's very difficult to compare them. But at the end of the day, and Silvia done excellent work, they both do respond very well and nicely to rehabilitation. And we do have the same answer to ourselves. How can we rehabilitate if we are doing transanal irrigation or anterograde irrigation? And this is something we do, and Silvia can tell you how she does.
Usually we start always with transanal irrigation because child at the beginning, for example, at 4 years old, it's too early for him for the patient to start the program. But then when we work, we start with working on the awareness. So we've, for example, we propose model, but then also working with mirror. So child start to understand what his pelvic floor is and how it does work. Then we start with some exercises and working on the awareness, they can understand what is the correct bowel signal. And then we start with more to create an independence from the transanal irrigation.
And I want to add that when we address a patient, let's say 3-4 years, they remove the nappy and they understand they are not continent. And we told that up to 7, it's very risky to start with a rehabilitation program. Therefore, we use the transanal irrigation unless they've got a real traumatic surgery and therefore they don't want anything to be inserted in the back passage. In that situation, we will propose a temporary anterograde Malone irrigation. But we use the other transanal retrograde or anterograde irrigation as a bridge towards rehabilitation so that they are clean, they are motivated when they start doing rehabilitation because they know that if they do it properly, they can get rid of the peristine or transanal irrigation or whatsoever. And this works very nicely because they grow up clean and not dirty.
Yeah.
There's another question, which is very interesting to me, because they're asking you, Silvia, thank you very much for the presentation. If one were to establish a similar program at one's own department, what would be your best advice for getting started? what do you consider the minimum healthcare personnel and professional competencies required to successfully implement such a program?
Okay. First of all, just only from my point of view, for example, we have the nurse that teach how to use the transanal irrigation. Then in our center, I think you need a physiotherapist that is specialized in pelvic floor, but also with some specialization in pediatric patients. Because, for example, in Italy, it's very difficult to find someone that can manage this problem in the pediatric patient. So maybe some, for example, I think you should search for a pediatric physiotherapist that is interested in pelvic floor rehabilitation, because it's very different, the approach to children. And then I think you need a room with a lot of toys, and we don't use a lot of different instruments out of the physiotherapist. So I think the main character is the physiotherapist and the doctor who manage all the clinical part.
Do you think that, I'm asking, the physiotherapist or the physiatrist, so the doctor and the nurse or the technician are both needed, or that sometimes the doctor alone or the technician, and therefore the nurse alone can do it?
I think depends. I think a interdisciplinary is very important. We speak a lot. We have a lot of interchange from me and physiotherapist, because sometimes she has some doubt for clinical problems, and then I can answer her, or she resolves some technical problem, and so I think it's very important to have both.
Okay, there's another question which is interesting to me. Do you inherit all postoperative Hirschsprung disease patients, or do you select from them which ones need your service? What is your main target group and the main objective with them? I think this is interesting, because in the paper we showed that we would propose pelvic floor muscle rehabilitation even to those who are asymptomatic. And before, I would have only addressed those with continence issue. Nowadays, I would ask Silvia to at least check them, even if they are asymptomatic, because sometimes they are asymptomatic when they are 7 and they become symptomatic later on. And I have a number of adolescents that they start complaining issues that if they did rehabilitation earlier, maybe they wouldn't have experienced. So in my opinion, it's better to have a sort of short treatment by Silvia to make sure that they understand how they work. Do you agree, Silvia?
Yeah, I agree.
Great. Thank you so much for answering all of these questions. I think we have answered them all at the minute. I will give people some more time to type in if they have any last questions. So my usual announcements that I do at the end is that the webinar has been recorded. I will be editing it and send the link to the YouTube recording to everyone who has registered for the webinar tomorrow. So you can always watch it back, and you will also receive a post-webinar survey after the session has finished. So if you're interested in the booklets, you can leave it at the comment in the survey, and then we can bring you in contact with each other. There is one last question.
Yeah, there's another anonymous author who asks you, Silvia, anything we can do to early educate and train patients who are younger than 7? I agree. This is something I think about when I got a patient 5 years of age with incontinence. I told what you can do from a technical point of view with a transanal or not, but maybe there is something you can tell them to maybe try to improve.
Usually when it's like less than 7 years old, we focus on the education of the educational part. So the education to toilet sitting routine, to introduce a correct routine during the day, every day at the same time, a bit of time on the toilet with the correct positions. So I think the gastrochoric reflex. So yes, I think we can work on the education part.
Yeah, we started when we started the very beginning period of this multidisciplinary approach. We started the rehabilitation in a patient that was 5, and he got frustrated because it didn't work as he thought, and he was not cooperative, and he never had any more cooperation since then. And now he's 13 and he's still doing his thing because he does not want to think about rehabilitation. So this is a war. I mean, if you start too early and they get frustrated, they don't want to do it anymore.
Yeah, I agree. That's why I stressed the concept during the presentation. It's very important to start in the right part at the right point.
Yeah, and we also include in the day hospital rehabilitation program psychological assessment.
Yeah.
Sometimes the psychologist tells us that this patient is not ready because maybe the frustration is something that he or she cannot cope with, or this patient is particularly mature and can do it earlier than expected. So we tailor the timing around 7 based on the psychological coping of each patient. And this is very interesting and useful as well.
Yeah.
Thank you. Thank you for the presentations and thank you for being here. I think it's very interesting and good that we touch upon all these different aspects that these patients go through in their lifetime. So thank you for the attendees also for being here, and I wish you all a very pleasant evening.
Thank you.
Bye-bye.
Thank you. Congratulations, Silvia. Very well done.
Thank you.
Thank you, Parmida. It's nice to see you.
Thank you. Thank you so much.
Good evening.